Good afternoon. My name is Marcelo Amato, and we are going to talk about recruitment. When does it justify a recruiting maneuver? I don't have any relevant conflict of interest for this talk. And the subject or the topic of recruitment has been very depressive in the literature in the last years, because some randomized trials produced very disappointing results. However, we believe that there are some explanation for this failure, and the literature is not all consistent in terms of failure. In fact, it has been missed that there are some very positive results in the last years regarding recruitment maneuver for a specific patient population. For instance, for a very severe hypoxemic respiratory failure in postoperative cardiac patients, and these patients can be considered to have a special form of ARDS. There was this very important publication by Lenny and published in JAMA, which showed that a recruitment maneuver can decrease the length of stay in the hospital or in the ICU and decrease pulmonary complications, and with a very significant results. Also, experimentally, we have shown many interesting results using the PET technology, positron emission tomography, showing that a recruiting maneuver and appropriate levels of PEEP can reduce a lot the lung inflammation. And finally, in obese patients, it has been demonstrated a survival benefit of applying a higher PEEP with recruiting maneuvers in this specific population of Boston. So the difficult part of the story is to prove that the recruitment and high PEEP could benefit patients in general in a wide population of patients with ARDS. You have to consider that the rationale is still valid. All mammal species, they suffer from villi, and all the models of villi, most of the models of villi, if you apply certain levels of PEEP and a recruiting maneuver, you can show some important drop in the lung inflammation. Why randomized trials cannot prove it? So this is a very intriguing question. One of the hypotheses is that the recruitment maneuver should not be applied for all. And we should first select patients that are recruitable. So the assessment of recruitability is a hot topic at this moment. For instance, this animal here, when submitted to pressure control ventilation with fixed delta pressure and just increasing the PEEP levels, we could see that there was a remarkable recruitment. So this patient has high recruitability. And in contrast, this other animal presents negligible recruitability because the lung was already fully inflated at low PEEP levels. So first animal is highly recruitable, second animal poorly recruitable. And for this second one, we should not try to apply a recruiting maneuver. So nowadays, we have electrical impedance tomography, and this helps us a lot to assess lung recruitability at the bedside. I consider the analogy of having EIT as the analogy of an old telescope compared with the new ones. So what you can do with EIT? I especially like some assessment of recruitability with a stepwise maneuver. How is it? So you start with pressure control ventilation, and this is the airway pressure recordings. And then with a fixed delta pressure, you just increase your PEEP level step by step. And then after 3 minutes, you go up and then goes down, you go down with your PEEP levels, and at the same time, you collect the data from electrical impedance tomography, which can be considered as an assessment of global lung volume. So pay attention to these analysis. First of all, what we can observe is that at the same PEEP levels going up or going down during the incremental phase and during the decremental phase, considering the same PEEP levels, I have a big gain in end expiratory lung volume, which represents an increase in FRC. At the same time, for the same delta pressure, I see a larger oscillation in lung volume, which means tidal volume. So tidal volume increases for the same driving pressure, which means that compliance also increased. So the comparison between these steps in the incremental phase and decremental phase can give us a lot of insights. And we can plot this sequence of maneuvers or PEEP levels in a very interesting way. So this is the plethysmograph produced by EIT. This is airway pressure, and this is a YX plot, airway pressure, lung volume here. So if I take the signal from both measurements simultaneously, I can plot, for instance, the tidal variations in pressures and volumes. So, and this slope of this line corresponds to tidal compliance, volume divided by pressure. Now, I take the next step and construct a new plot, which is the tidal compliance for the next step, and plot in the same graph. Now my PEEP level is higher, so I have a displacement of the curve to an upper level, and so forth. Now let's do the same thing in a different patient. Look what's happening here. There is a displacement of this curve to higher levels. What does it mean? This means recruitment. For the same pressure, I'm operating now in a higher lung volume. So I can compare this patient against this patient. This patient does not recruit. And in contrast, this patient is presenting some recruitability, like this one. So whenever I have this big vertical displacement, I consider that this patient has high recruitability. In contrast, this one does not have any. So applying these principles, we have been able to construct an online calculator of recruitability. And for instance, if a patient presents with this type of behavior during this maneuver, I can construct a curve like this, which means that this patient started at 20% of the lung recruited and finished at 90%. I don't have time to go over the calculations here, but this has been validated in a study against CT. So whenever you see this behavior, you know that this patient has high recruitability and it can compute online. In contrast, this patient, if I calculate the recruitability, I see that I can calculate that this patient was already recruited at the beginning and didn't change at the end of the maneuver, meaning that this patient should not be submitted to a dangerous recruiting maneuver. So we did this kind of approach in a sequence of patients with COVID-19 disease. And this is in blue, the airway pressure tracings, in which we had a baseline PEEP of 6, we increased to 16, got back to 6, performed the recruiting maneuver, and then a decremental PEEP trial. And finally, we recruited the patient again and submitted this patient to this, let's say, ideal PEEP. In some patients, this was the clinical PEEP chosen by physicians. But the important aspect was this evaluation during this period of time, okay? Let's show you some results when we compare the results at the first 6 of PEEP with 16. And also, let's compare what happens if I take a PEEP level of 16 against the PEEP level of 16 after a new recruiting maneuver, because this one, I just increase PEEP from 6 to 16. So it's an incremental use of PEEP of 16. While this patient here was using 16 of PEEP after a recruiting maneuver. So it is possible that we see a completely different behavior here. Let's check. First of all, comparison between 6 of PEEP and 16 of PEEP. Big drop in lung collapse, boom, except for 1 or 2 patients. So these are 40 patients with COVID-19. So it looks like that almost all patients had a decrease in lung collapse. But let's check what happens with hyperdistension. Well, big increase in hyperdistension. Almost all patients, except for 1 or 2, increased hyperdistension. As a result, if you look at compliance at 6 or 16 of PEEP, compliance is about the same, because depends on this combination of collapse reduction or increase in hyperdistension. You can have some benefit or not, but you can clearly see that some patients improved a lot the compliance when, or decrease a lot compliance when they increase PEEP. Sorry, so these patients increased compliance and these patients decreased compliance. And now finally, you can see what happens with, now I'm applying 16 of PEEP before and after a recruiting maneuver. And I can clearly see that first, collapse decrease in all patients. Hyperdistension also is slight decreased. And as a result, compliance improved as an average for all patients. So, which is the conclusion of this analysis? And this is my last slide. Having a very good assessment of recruitability at the bedside is very important, because for some patients, there is a big advantage in increasing PEEP, while for other patients, there is a big advantage of increasing PEEP. This is clear from this analysis, because you never can predict how much hyperdistension or collapse reversal you are going to get after applying a certain PEEP level. But most important of everything is that if you are applying a certain level of PEEP, like 16, because you believe that this patient needs, it's always desirable to apply a previous recruitment maneuver, because you systematically get an improvement in compliance and a further decrease in collapse. And also in average, you can also decrease a little bit hyperdistension, like in these patients with COVID-19. So if you are going to apply a high PEEP strategy, this has to be applied after a recruitment maneuver. Thank you very much.